Hey everyone, welcome and welcome to the webinar. And if you're here today for thyroid, rheumatology, and the eye, you're in the right place. With that being said, we are about 2/3 of the way of the people entering the room. So I'll do a little bit of housekeeping. I will launch the handout here shortly, and we will do a polling question as a test here because in order to do the meet the regulations, we have to show that it's interactive. So that's part of it. This course is being recorded, this part right now. There will be a replay sent out tomorrow with a survey. You'll get a survey about 2 hours from now. Please fill out the survey. We need that for, again, the regulatory bodies that are out there. With that being said, we do have a YouTube channel. You can find it on our website, or you can just go to YouTube and just type Optometric Education Consultants. We already have all the past webinars there. Depending on how quick Webinar Jams turn this around, I'll either have it there tonight or tomorrow on the YouTube channel, but it is being recorded. Again, a survey will be sent out tonight. Please fill that out or fill it out tomorrow. Probably the biggest issue that we get is, hey, things could be clearer, things could have been smoother. This is all uploaded into the cloud. So really it's the connection between Webinar Jams in your house, and not sure if your bandwidth at home, but everything at home now runs off of Wi-Fi, my scale, my doorbell, my refrigerator, all this stuff. So if you have people that are doing gaming or streaming movies right now, it'd probably be the best thing to do. Or if you're doing multitasking on your computer, just try and decrease the bandwidth and you'll get really good images. We'll use the chat section there. It should be on the right-hand side. There's a chat section there that we'll put questions in there. Dr. Saka will monitor those questions. I won't be able to see the screen because I'm going to go to a full screen with my presentation. The polling question, we'll test one here in a second. I'll get the handout launched. And the last thing I like to mention is Vanessa is our conference coordinator, and she'll send this information to Arbo this week sometime. But Arbo is about 7 days behind, so it won't get uploaded into your OE tracker and to be able to be printed on that end or to be able to see it for probably about 7 days. Maybe about a week, but we will send you a letter of certificate. So, and I'll remind everyone at the end that that's going to happen. I'm going to launch the handout right now. If you guys see files, if you see the files, I'm going to do a full page and I'm going to share it. That's the whole, and you can download it and you can have it and review it and look at it or do it now. And I'm also going to share what we typically see, in presentations, the 6 slide per page. So they're there. Joe, do you want to make some comments and do a test polling before we get started?
Well, I want to welcome everybody to the webinar. I'm sure we have a lot of people that have participated before. And we're in the process of putting together some more webinars. And we're even going to put a practice management one up, which will actually be allowed in the state of Florida. Everybody else in Florida cannot get online CE at this time. So with that, I'm going to just give a quick practice poll right here. And I'm going to start. And where is your practice regarding COVID-19? Is it closed? Open only for emergencies and urgencies? Open with a reduced schedule? Open and back to normal with a normal patient count? Or open and busier than before?
And if you guys are not seeing it, you'll see on the right-hand side, I have a few extra ones. I have settings and attendees and chat, but go to the poll. You'll see where it says poll. There's probably a little orange dot there, and you'll be able to see it because I see sometimes people answer in the chat questions, and that's why we do this test here. So go to the button that says polls, and you'll be able then to select an answer.
And actually, we're very, very close. Open with reduced schedule is slightly ahead of open and back to normal, and a little behind that is open and busier than before COVID.
And this is great because, Joe, what have we seen? We've seen that kind of tilt the other way, right? So we started doing these back in March, April, and everyone was closed and only urgencies and emergencies. And it's great to see, um, you know, the people are, in a sense, returning back to normal. All right. It looks like we have most of the people in here. I'm going to turn on my screen share. And any comments before I get started, Joe?
Well, not really a comment, but I do want to take the opportunity to introduce you to everybody in case anybody is new. You know, my partner in OEC is Greg Caldwell, Dr. Greg Caldwell, a 95 graduate of Pennsylvania College of Optometry, where he completed a 1-year residency there in primary care and ocular disease at the Eye Institute. He's a fellow of the American Academy of Optometry and a diplomat of the American Board of Optometry, the ABO. Currently working in Duncansville and Johnstown, Pennsylvania as an ocular disease consultant. Greg's primary focus is diagnosis and management of anterior and posterior segment ocular disease and has been a participant in multiple FDA investigations. Dr. Caldwell has lectured extensively throughout the country, our country, and over 12 countries internationally. In 2010, he was the president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees for 2013 through 2016, and he's president of the Blair Clearfield Association for the Blind. So with that, I'm introducing our speaker and my partner for this evening, Dr. Greg Caldwell.
Thank you, Joe, and thanks for the kind introduction here. Before you go to turn off the microphone there, are we live, able to see the slides on your end?
Indeed, I can.
Perfect. Thank you. All right. So here we are. We're going to do rheumatology, thyroid dysfunction in the eye. And let me tell you that this is probably one of my funnest, most, I can't always think of the words when I get to this point, most impactful, unraveling lecture that I give to optometrists, especially on the thyroid side. So in doing this lecture and hearing the feedback from the audience, I moved thyroid up. So it's going to be thyroid, and we'll probably touch a little bit on the rheumatology side. But once we understand the thyroid side, then the rheumatology part falls right into place with the eye here. So here are my disclosures. Really not much. You can see I do a lot of advisory boards here. Let me turn on my laser pointer here because I know my pointer's not showing up. You can see I do some advisory boards, and I do lecture for some companies. I'm not going to read this all to you. Really, the one I'm going to point out is in the last week, I did sign a contract to help Dompe out, and we'll be talking about Oxervate, but they're not paying me anything to do with this this talk tonight. Learning objectives are in your handout. Thyroid disease and thyroid eye disease. Let's just jump right into it. The thyroid is an endocrine gland, and remember there are two types of glands: endocrine and exocrine. And the key with the endocrine system is basically it's a ductless system. It uses chemical messengers, hormones circulating through the lymph and the blood to talk to those distant organs. And here is a list of your endocrine glands right here. I'm not going to read them to you, just take a look at it. That's the endocrine system. The exocrine gland contains ducts. It's using tubes and glands. And one is, like the digestive enzymes that come from the salivary gland, sweat glands, and they secrete maybe enzymes. And really one of my favorite organs to help remember this is the pancreas. We all know the pancreas, and we know that it does secrete digestive enzymes into the small intestine. That's the exocrine side. But then we also have an endocrine side, which is the ductless part of it, which is the insulin and glucagon that gets secreted into the bloodstream. So if you ever need something to remember the pancreas, and the insulin and glucagon is the endocrine side, and that's why they see an endocrinologist. But yet the exocrine side is the secreting digestive enzyme side. So the thyroid is the largest endocrine gland in the body. It's butterfly shaped. There's two lobes. It's right beside the trachea, just below the skin and muscle surface. The thyroid controlled by the hypothalamus and pituitary, and we're going to chat that here shortly. Now, the primary function of the thyroid gland is to produce T3, T4, and calcitriol. And remember that, because that's what gets us into trouble, and that's what you're going to become experts, and you're going to have to battle, in a sense, as you become an expert in this arena of thyroid. You're going to have to talk to the endocrinologist, and you're going to have to talk to your PCPs, and I'm going to talk about that here shortly in a second. So with that being said, Joe, we're going to be launching polling question number 1 right now, and I think it has to do something with diabetes and thyroid. Like, which do we see more in our practice? So polling question number 1, remember, I can't see them. And you're muted if you're reading off the question.
Thank you. Which patient comes into the office more often? Patients with diabetes or patients with thyroid disease? Or it's about equal. And we're working away. Patient with diabetes is coming up. We have a few more seconds for our interactive part of this program. And it looks like we have a winner. Patients with diabetes is far ahead of patients with thyroid, and it's certainly not equal. Okay. Excellent, guys.
Perfect. Thanks, everyone. And thanks for running that polling question. They'll be coming pretty quick, and then they'll die off for a while, and then they'll come towards the end of the lecture. All right. So here's what I want to point out. And actually, these numbers need to be updated, because these numbers are up to about 30 million and 30 million. Where we have about 30 million people with diabetes and 30 million people with thyroid. And that's why I like putting the polling question up before this slide is, and I think we as optometrists say we see more diabetes patients, and maybe it's just the way the question I have it worded, is that we see equal amounts of people with thyroid dysfunction and diabetes in our practice, but we probably see more complications from diabetes, and that's why we answer that. Or hopefully after tonight's lecture, you'll realize that maybe you're seeing more thyroid than maybe you're realizing, and that's the purpose of being here tonight. So let's remember that.
Excuse me, Greg.
Yeah,
Greg, let me just interrupt something I'm seeing in the chat.
Yeah.
It's not a question, but people are having some connection issues. There is a reconnect button. Go to that and just reconnect. Greg mentioned it, but it is very important. You've got to limit your bandwidth in the house. So any other program on your computer, you're going to have some difficulty. And if other people are gaming or streaming a movie, it will impact this program. But go to your reconnect button. Take it away, Greg.
Perfect. So thanks, Joe. Thanks for doing that. And so again, I think we see more people with diabetic complications, ocular complications, and that's why we answer it. But I was a geek one time. We have 6 exam lanes, and I put a sticky in each one. And every time I saw a patient that had a thyroid dysfunction or was considered diabetic, I put a little tick mark done. Did it for about 6 weeks, 4 to 6 weeks, and at the end, they were about equal amounts. So make sure if we're looking for patients with diabetic ocular complications or issues, we want to look for those thyroid, and that's why we're here tonight. So here's what we're talking about. The normal thyroid function starts way up here in the hypothalamus with producing thyroid releasing hormone. Remember, this is a ductless system, and it talks to the anterior pituitary, and then that produces the thyroid stimulating hormone, which then produces the T3, T4, TSH, and that calcitriol. Now, here's the whole lecture right here. This guy walks into my practice and he goes, "Hey, doc, I talked to my primary care doc, and, I hear you're pretty good about, eye care stuff. But if you tell me I have a thyroid problem, I'm just going to get up, walk out. You don't get a copay. I'm out of here," so on and so forth. I said, "Okay, that's fine." So we're looking at him, and you can see I've taken some pictures, a little bit of redness here on his eye. He's got a little bit of, bulging, maybe a little bit of lid retraction, or maybe it's just anatomy. But he reports he gets some redness every so often. It kind of comes and goes. So this is the patient that I kind of couched it, and I said, well, it's kind of neat. There is a condition out there within the thyroid family that you don't really show up on blood work as having, being dysfunction, but the the thyroid dysfunction is actually affecting the eyes. So he kind of was like, wow, that's kind of interesting. All these people are thinking thyroid, but maybe they're kind of barking up just the wrong tree. So we did the exam, and I'll kind of show you how this all plays out. So this is really the key of understanding thyroid eye disease part of it. So before this is in a form of a question, Joe. So can you just launch this question? Because I'm kind of curious to see how the audience answers this. This is exactly how you guys are going to see it in the question. What is the most common cause of thyroid dysfunction? Cancer, surgically induced, medical toxicity, pregnancy. This is the only one that I have in here, Joe, because it's part of my lecture, and the immune disease, autoimmune disease.
So what is the most common cause of thyroid dysfunction? Cancer, surgery, medicine, pregnancy, or autoimmune disease?
So remember, everyone, go to polling and plug in your question or plug in your answer.
Hold on. Oh. We had a bit of a delay there, but now we are cooking. And far and away in the lead right now is autoimmune disease.
Great. So it seems like everyone knows that answer, or a majority of the people, and I'll just keep moving along here. In an autoimmune disease, the body typically produces what that attacks itself, and can be systemic or organ specific. It can be just attack the whole body or just attack a certain organ. Our fancy word is immunoglobulins, but antibodies. And you guys are going to be sick and tired of hearing me say that at some point, probably through tonight. Now, it's not in a sense of a polling question. I don't think I have it as a polling question, but ask yourself, thyroid eye disease, what type of condition is this? And if you're going to send it to a specialist, which specialist would you send it to? So, is this a cornea specialist? Is this a retinal specialist? Is this an anterior segment or glaucoma specialist? The answer is no. And it's kind of this kind of unicorn type of doctor that does exist. This is an orbital disease. This is an orbital disease consultant. And these guys do exist. So one of my clinical pearls is, mine are about 70 miles away from me, depending on which way they go. They can go to kind of the Harrisburg area, that kind of cheated a little bit on this way, not all the way out to Harrisburg, but then to Pittsburgh, 70 to 90 miles and up into Geisinger area for me. I like to know where my orbital disease specialists are, because as I get through the talk, you'll see a gentleman that needed to get to an orbital disease specialist. So when you think of thyroid eye disease, it's an orbital disease condition. And you're going to kind of see this play out as we go through the webinar. So now, thyroid dysfunction. Joe, go ahead and launch that polling question. And I'm just going to talk real quick that primary is of the thyroid gland. Secondary is if you have pituitary failure. And then tertiary would be hypothalamic. But let's do the polling question.
Yeah, is thyroid eye disease caused by TRH, TSH, T3, T4, or TRH, TSH, T3, T4, or thyroid receptor antibodies?
So that thyroid eye disease, how do those eyes, when we see them in the office, remember we learned no specs, right? We learned about no specs and how no specs can, and that's an acronym that's out there. So how does that eye, is it the TRH, is it the TSH, is it T3, T4, or is it these antibodies that we're talking about?
All right, looks like thyroid receptor antibodies looks to be the winner.
All right, perfect. So maybe I greased that skid a little bit. So let's just talk about this real quick before I move on to the next slide here. The whole idea is people come into the office on Synthroid. Who's at risk in a sense for thyroid dysfunction or thyroid eye disease? So ask yourself, let's say you're having, you're at top of the game. It's Monday, great weekend, well rested. You go in and you're doing confrontation fields, and you find this bitemporal hemianopia. And the patient, goes in and they have a pituitary adenoma. They go to get an MRI. It's confirmed. They have surgery. But remember, this is a ductless system. So TRH is being performed, but they had to remove the pituitary gland because of cancer. That patient ends up on Synthroid. Someone has a closed head trauma, maybe from an accident, or maybe has a stroke or some type of hypothalamus issue, and they can't produce thyroid releasing hormone. Well, if they can't produce thyroid releasing, thyroid stimulating, and then T3, T4, it's kind of a chain of events. All these people are going to end up on Synthroid. Are all these people at risk for thyroid eye disease? If they're on Synthroid, are they at risk? And the answer is no. And so that's what we want to point out, and I'll kind of make that clearer as we go through the talk here. So there are these antibodies that I keep referencing, and it's thyroid stimulating antibody, there's thyroid blocking antibodies, there's thyroid peroxidase antibodies, and these are the antibodies that are produced in the autoimmune side. So if someone has a pituitary adenoma, these antibodies are not being produced. Yeah, they ended up on Synthroid because they had to remove the pituitary gland. So my point here is, here are these thyroid stimulating. Here they are attacking the receptor, right? It's an antibody receptor. So these antibodies are attacking the receptors on the front surface. So it stimulates the thyroid gland. And now this is what we see with in a sense, the person that is hyperthyroid at the time of their diagnosis. T3, T4, and then TSH, because it's a negative feedback loop, because there's so much T3, T4, and that's what we learned what hyperthyroid is. When you get the blocking attacking the thyroid receptors, it decreases the T3, T4. You get the increase in the TSH because it's a negative feedback loop, and that's what we learned in hyperthyroid. Now, I'm just going to animate this whole slide right here and just bring it up. And this is what I was referencing before. Here are all these primary and secondary causes of why people, in a sense, can end up on Synthroid. Someone can have a toxic adenoma under the hyperthyroid, and they get that fixed, or they have excess iodine. These patients will eventually end up on Synthroid, but these aren't at risk for the thyroid eye disease, just like this group over here isn't. It's this autoimmune, because the autoimmune is tagged antibodies. So what's one of the things I try to do when someone comes into the office? What I try to do when someone comes into the office is I try to figure out if they're on Synthroid. So I see that they're on Synthroid or some other medication, but that's the most popular. But they're on Synthroid. And I try to figure out, are they autoimmune or not autoimmune? Because those are the ones that are at risk for these thyroid eye conditions. And this is what we learned back in school so much, right? The Graves' disease, it's a multi-system disorder, hyperthyroid, the infiltrative dermatopathy. That is where you see the skin around the ankles becoming attacked. And the skin around the ankles becomes attacked because it's an autoimmune. And guess what? There's tissue around the ankles that looks like thyroid tissue, so it becomes infiltrative and inflamed. And that's where the infiltrative or ophthalmopathy comes from, or the thyroid eye disease. And you can see here that females 7-to-1 are more likely. So I spoke with a genetics person, and I said, why are all the autoimmune people why are females generally more attacked in higher prevalence in autoimmune? And the genetic person said, well, they thought it was because the immune system is part of the X chromosome. And since females have two X's, they have a double chance of it happening, where males are XY. And so there's half a chance of it happening, because it would just have to have the one X if that's for the immune system. So I never really checked it out, but I thought that was a pretty neat way, or at least a nice way to remember that most autoimmune affects females, more than males. But we can be fooled by that because I'll show you my patient coming up here. So this is Hashimoto's, hypothyroid. This is an autoimmune disease. Autoimmune means the antibodies, and this one has a goiter formation. Again, let me point out here, I clicked it a little fast. Look what the cause is, right? It's these receptor antibodies, thyroid receptor antibodies that are attacking the thyroid. The same thing here with autoimmune atrophic thyroiditis, kind of a hypothyroid, but not a goiter. Key here is we don't really have to differentiate out. It's nice to know this information when we're working with the endocrinologist or the primary care doc. Just know that it's autoimmune, which means these antibodies are there and it can attack the orbit. And the same thing can happen in postpartum thyroiditis. The women develop the antibodies during pregnancy here. So here's the whole key before we jump into the signs and symptoms here. Here's the issue with thyroid eye disease. Unfortunately, the muscle and the structures, mainly the muscle and fat within the orbit, look like thyroid tissue, look like thyroid receptors. And that's why when the body produces the antibodies, that it goes and has a potential of attacking the eyes. It's really not the T3, T4, and TSH. It is initially, I'll take that back here in a second, but what I want to hone in on is whenever the TSH and T3, T4 are perfectly normal, how the heck can Dr. Caldwell be telling the patient that they're having thyroid eye problems? Because when they go to their primary care doc and when they go to their endocrinologist, hey, your T3, T4, TSH is perfectly fine. Hey, he's just an optometrist out there. Maybe we should get another opinion. And that's when I make the phone call and say, look, I'm not sure why you're doing this. You guys are the experts in this area. Don't you know that this is an autoimmune disease? It has really nothing to do with T3, T4. Yeah, you're doing a great job managing that, but now these antibodies are attacking the orbit, the soft tissue, the muscle, the fat, and creating all these problems. And this is what we've learned in hyperthyroid is that the symptoms, right? There's too much T3, T4. They're really nervous. They're heat intolerant. They're sweating. They have tremors, tachycardia. And the opposite is for hypo, right? Things are cold intolerance, weak, monotone, bradycardia. We've all had that beaten to our head. These are all the different names that are out there. I kind of avoid these Graves' disease because they're more tagged. You're saying if they have Graves' disease that it had to be associated with hyperthyroid. I don't mind these ones, thyroid-associated orbitopathy, because what does it remind us? This is an orbital disease. That's where this falls. It's not cornea, it's not retina, it's not glaucoma. It's an orbital disease, thyroid orbitopathy. Or thyroid eye disease just reminds me that it's the thyroid antibodies creating this issue. So why is it so confusing? Thyroid eye disease is seen in conjunction with Graves' disease. It's seen in conjunction with Hashimoto's. It's seen in people like the guy that I showed you at the beginning of the lecture with no evidence of thyroid dysfunction. Hey, my T3, T4 is perfectly fine, TSH, but yet I'm having the orbital part of this disease? Absolutely. That's what's happening to you, sir. So most thyroid patients, however, will not develop the thyroid eye disease, right? So they're autoimmune. And that's why I think we get fooled sometimes and lulled into our practice. Or maybe it's a little bit higher prevalence than we think because we're not sure exactly what we're looking for. And that's why we're here tonight. So why is it so confusing? The eye symptoms usually occur at the same time. However, they may precede or follow the symptoms that are associated out here. We're going to be talking about smoking here in a second. And this is where it comes into play when you're talking about successful treatment of the gland does not guarantee that the thyroid eye disease will improve. So in other words, and I'm always sensitive because I know with 30 million Americans, and I've given this lecture enough times live, that people come up to me at the end and say, hey, thanks for doing this. I have thyroid, I'm autoimmune, and I was kind of curious. So I'm sensitive out there that there's probably someone in this audience that that has a thyroid dysfunction, autoimmune, and potentially could have this happening to their orbits. With that being said, successful treatment, taking your Synthroid does not guarantee that your eyes will improve, does not guarantee they're going to continue not to deteriorate, right? Remember, because it has nothing to do with T3, T4, it's these antibodies. So let's jump into this a little bit deeper now. So thyroid eye disease. If I had if everyone on this webinar tonight, we were having a thyroid eye disease support group. And everyone in here had thyroid eye disease from one extent to the other, mild to severe. We're just here tonight because of thyroid eye disease. It's a support group. And I had you raise your hand. And I said, how many of you were hyper at the time? About 80% of you would raise your hand. And I said, how many of you were hypo at the time? About 10% would raise your hand. But 80 and 10 only equals 90. What about the other 10%? The other 10% are have a normal thyroid. This is the guy that walked into my practice. They have a normal thyroid function. T3, T4, TSH is fine, but these antibodies are still being produced and creating the orbitopathy that's out there. So here's another pearl that I do. When I have someone that comes into my office and I see they're on Synthroid, what do I try to determine? Okay, did they end up on Synthroid because they had a pituitary tumor, they had the pituitary ectomy, and they ended up on Synthroid, very low risk of thyroid eye disease? Were they autoimmune? And if so, were they hyper or hypo? Because look, if they're hyper, then there's the 80% chance. Those are my high risk patients that are out there. And when you see this right here, this 10%, you'll see this term euthyroid that's out there. And we're going to talk about that here coming up. So what causes those signs and symptoms? All right. I lied a little bit, but not much, because I really wanted to focus on this. When you first have that blast of T3, T4, if you're hyper, you do get some eye signs. But as the endocrinologist is regulating the thyroid gland, the eye signs will go away. What we want to focus on is this later phase. So there's two phases in thyroid eye disease. It's the first phase is this increase or decrease in this free T3 or the free T4 levels. That kind of goes away. We as optometrists really maybe interact with that, let's say for 2 or 3 months, because it's just mainly lubricants, maybe some steroids, so on and so forth. And then that goes away because of the normalization of the T3, T4. But that doesn't mean that later in this congestive phase, and that's the new words that's out there when you talk to these orbital disease specialists, it's this congestive phase, this autoimmune, this inflammatory phase, the antibodies attacking these tissues. And this is where the key is trying to determine if it's in an active phase or a resolution phase. Obviously, if it's inflamed, we're doing a lot of steroids, a lot of anti-inflammatories out there. There are some surgical corrections. We know surgery is kind of a controlled type of inflammation. We really don't want to be doing surgery unless there's risk of losing sight. We want to determine if they're in the resolution phase, and you'll see some treatments out there that we can do for these patients. With that being said, a lot of people will say, hey, what's that timeline? Well, that's the $1 million question. You kind of have to follow these patients and see if the inflammation is burning down. Remember, it's a receptor disease. So that's why eventually the receptors get damaged on the surface of the thyroid. That whole system kind of burns out. The thyroid for the very first few years is very hard to regulate because the receptors are still there, some blocking, some stimulating. That's when you hear, my thyroid's out. You hear that sometimes. But that kind of normalizes as the receptors get damaged and there's no receptors to respond. And that's why then the patient ends up on Synthroid. But that doesn't mean that they're out of risk for now. They're going, those antibodies are not on the thyroid. Let's go check out the orbits. And then that starts. And that can be anywhere from 1 to 3 years. And then within that starts, that's where it could be active plateau or resolution. So this is the slide that, kind of is identifying the T3, T4 reaction that we've all been taught in school, in a sense. Hyperthyroid symptoms, the excess hormone hitting the nerves. You get that staring, that spastic look because of all some dryness, some lid retraction. And then in hypo, right, things are slowing down. You got the deficient hormones. You get venous congestion, impaired circulation, a little periorbital edema that's out there. That all kind of goes away whenever you have that thyroid back in regulation by the synthroid. And, if you're trying to follow this stuff through T3, T4, that's going to lead you down that rabbit hole that you don't want to go down. Here's where I'd like to focus, and this is kind of where we unravels. We want to talk about this congestive phase. We're talking about these thyroid antibodies attacking the orbit. And that's where we're going to focus on the rest of this talk. And again, the active inflammatory phase versus are they moving into the plateau, or are we in the resolution phase will help us to determine how we're going to be treating these patients. So the question now is, how is a patient that has autoimmune, how quite possibly can 10% of them just have normal T3, T4? Now, when patients have autoimmune, what happens is you get all the antibodies being produced. If it's a scale that tips to the thyroid stimulating, you get the hyper. If you get more that are blocking, then you get the hypo. But what happens if you just get that equal amount of antibody attacking those receptors? You get a nice amount of blocking, a nice amount of stimulating. T3, T4 is never really unequal, and you have the proper amounts. They're not out of balance. And now the key here is what do you have being produced? The antibodies. So the T3, T4 is perfectly normal. You're running lab tests on those patients. Looks great, but why are their eyes red? Well, it's because the antibodies are attacking. So these are all patients that have come in, and now you can start seeing the lid retraction that's occurring. You can see in the patients, they have a little bit of exophthalmos. You can see the orbital edema. This one's a little bit more active, right? Look at the redness that's around the eyes. But my point of this is maybe it's thyroid stimulating, maybe it's more thyroid blocking, but what happens if it's just a nice mix? The antibodies are the antibodies. They're attacking the orbital structures, creating the inflammation. So that's really the key to thyroid eye disease. Here's a patient of mine that came in, very similar to the gentleman that came in. Hey, look, I'm always being put on this Lotamax. I'm put on Toberdex. I have these eye problems. I have this discomfort. It kind of comes and goes, so on and so forth. So I see that she's on Synthroid, at the time, and we start talking. And so I didn't really see her till right down here until around 2016. But I talked to her and I said, hey, what happened? Tell me about this Synthroid. And she says, well, yeah, back in 2014, I don't know, I was heat intolerant. I was this, I was that. And I finally figured out that, I was maybe hypothyroid, because you could see how high this number is. And you want those numbers to come down, but I was tired, so on and so forth, whatever her symptoms were. But she had a bad year until they figured out that she was having a thyroid problem. And so they started regulating her back in 2000, and she had the antibodies in 2014. It was creating this disruption. So all along, she keeps going to eye docs and so on and so forth, and been put on steroids. So I said, you know what, do me a favor. When I see her in 2017, I said, I want you to do me a favor. I'm going to run this lab test. It's not your standard T3, T4. I want to see if you have these antibodies and what's happening. So check out these normal values. Thyroglobulin should be 20 international units per milliliter. Peroxidase should be less than 35 international units per milliliter. And the TSI, the thyroid stimulating immunoglobulin, should be 1.5. These are kind of normal values. I gave her the blood work. Now, my hospitals can do thyroid lab 1 or thyroid lab 2, but they're just variations of T3, T4. They were able to draw the blood work, send it off to Quest Laboratories, and they got plugged into her electronic health records. And so she was able to pull all this up and write this down for me. And, when she got the results on October 10th, 2017, her thyroid globulin was less than 1. Okay, great. It should be less than 20. Her peroxidase antibody was was 11. It's like normal's less than 35. My number here is 1.75. Her number here is 1.3. And her thyroid stimulating immunoglobulin was 344. So whatever that comes out to be, it's almost 300 times higher than what it should be. And you can see here now she has a ton of thyroid stimulating immunoglobulin that is circulating throughout her body. And unfortunately, the orbits and the muscle and the fat look like this this receptor tissue, and that's what's attacking. So this is really the key. So, this patient could quite have well, I'm not sure, it happens all the time. I call PCPs up all the time. I'm not sure what Dr. Conwell's talking about. Look, I'm decreasing your synthroid. Your numbers look great. I have no idea why he's telling you your thyroid is affecting you. I'm telling you your thyroid's affecting you because it has nothing to do with T3, T4, TSH. It has to do these antibodies. And I can't tell you how many mysteries I solve just by running this blood work. And all you got to do is write thyroid antibodies, ocular, thyroid eye disease is the diagnosis, and let the blood work be run. And a lot of times in my hospital, and I only have one hospital in my area, they know that I order it and they know what I want, and then they send it out to Quest Laboratories. They draw the blood and send it over. Sometimes PCPs have the laboratories. You have to call and talk to the PCP. Why are you doing this? Their T3, T4, TSH has been great for the last 4 years. Well, they have eye signs, and I think it's the antibodies that are attacking it. And I want to make sure I'm doing the right thing, because let me tell you another little secret who I use to treat the inflammation. It's the second half of this lecture, or it might actually be a third of the lecture that we get to, because we like to focus on the thyroid part, is the rheumatologist. Who treats inflammation any better? And I'm lucky I have this 8-man woman rheumatology practice literally 1.5 miles from my office. I get a ton of their patients sent over for the Plaquenil testing and all the dry eye and all the inflammation and uveitis that can occur from those conditions. But the good news is I've explained to them about these antibodies, because that's all rheumatology is, right? It's autoimmune. And this is autoimmune. So my secret is, who do I send sometimes to do these steroids and manage the patients? Is I send them to the rheumatologist. And so my rheumatologist, luckily, one of them rotated through a eye clinic, and he's awesome to work with because he totally gets how the eye is involved with a lot of these conditions, and we get them treated with IV steroids or oral steroids or whatever is needed. So that's pretty cool there. All right, time to move on to the next slide. So I think we're all aware, we've had it beaten to our head when we went to optometry school, and or when we had to take therapeutics courses as we expanded our licenses, prominent stare, pain, lacrimation, lid swelling, foreign body sensation, double vision, photophobia. This is kind of all this no spec stuff. I kind of like no specs. It kind of reminds me that there could be no signs or symptoms, or maybe just the upper lid, and now we're getting into soft tissue. This is probably what we're missing in our office most of the time. There's probably soft tissue involvement. It's that patient. I want you to kind of think of that patient that's coming into your office every, couple months. You're putting them on Lotamax, you're putting them on Tobradex, Maxitrol, some type of steroid. They're not bacterial, they're not viral, they're not contact lenses, they're not allergy. Where the heck's this coming from? Next time you see Synthroid, I want just this lecture to echo in your head, because that's probably what's happening. They're having that soft tissue involvement, that inflammation. Proptosis, extraocular muscle involvement, cornea, and sight loss. That kind of reminds me, and there's this whole grading system, but we don't really use these grading systems. That was 1969. These docs came out in 1991. Lid, exophthalmos, muscular, optic nerve. It kind of narrows it down. Remember, lids, exophthalmos, muscles, optic nerve. But again, it just kind of reminds us what can happen to this. What the problem is, it doesn't tell us if it's the congestive phase, it's the inflammatory phase, and then if so, are they in the active, or are they moving into the resolution phase? And that's kind of where we are when it comes to thyroid eye disease. Know all the things that can happen. It's congestive. Now the key is it inflammatory or passive. So these are all the things that can happen with the lid. So we can see here that we have some lid retraction. And as a reminder, we know that eyelid should hit about that 10 o'clock and 2 o'clock position, and we're seeing the eyelid being retracted here. The von Graefe sign, the patient looks down and the eyelid stays up. And lag ophthalmos, it's either due to the lid retraction, the lids don't go closed, or maybe it's due to exophthalmos and the proptosis that the cornea is being exposed. Soft tissue involvement is chemosis, periorbital edema. This was a patient that came in, looked classic like viral. Hey, why are my eyes? But this viral keratitis, this viral conjunctivitis, not keratitis, conjunctivitis, has been going on, and she responds well to Lotemax. We tested her antibodies through the roof, and we solved her issue. She was having thyroid eye disease. This is the soft tissue involvement. Now, this is kind of neat. Now, you see this SLK, superior limbic keratoconjunctivitis. When I see this in the office, you pull the eyelid up, you have the patient look down, classic SLK. Check this out, 65% correlation with thyroid disease. Pretty neat. Just click over to your electronic health record or your medical record if you're still paper, and find out what the medications are and go, boom, oh yeah, I see that that you're on Synthroid here. This is that soft tissue involvement that's causing this. Your eye is being attacked. It's this inflammation. If it's not, then look what else are the culprits: rheumatoid arthritis and Sjogren's. What type of diseases are those? Right? Autoimmune. Autoimmune means what? Immunoglobulins, antibodies. So look at this. High correlation of superior limbic keratoconjunctivitis is due to this antibodies that are out there. And here's Dr. Andy Morgenstern. I took this picture because he lectured for one of the conferences that Joe and I put on years ago, 2013. So this year will be the 7-year anniversary of Dr. Andy Morgenstern saying this is, if it's red, think TED. So think thyroid eye disease when those eyes are red. And I cannot be more of an advocate of that. Periorbital edema, the inflammation of the subcutaneous tissues. It may be the first sign of thyroid eye disease. You just have this orbital tissue that's swelling, and it could be greatest in the morning. Now we're getting into the infiltrative orbitopathy. And this could be unilateral or bilateral, and it might need to have an MRI to determine this. So it's basically an inflammatory. It's like lifting weights. You lift weights, you tear the muscle, it swells, it gets bigger. You're kind of doing that through an inflammatory process and getting fibroblasts and edema into the interstitial tissue of that muscle. And the key here is it can be unilateral, right? Right off the bat, you think, oh, geez, this patient probably has an orbital tumor. But don't forget that thyroid eye disease can be unilateral or it can be bilateral in nature. And here's the MRI showing you the issue and the muscle being infiltrated and hypertrophied. So here's another case of a unilateral presentation. Look at this normal presentation. Look how this eye is. Ooh, it could be a tumor, but then just take a look at this, in a sense, medial rectus muscle compared to the lateral rectus muscle. Look how large and inflamed, and look how that eye is being just pushed, in a sense, nasal to temporal and being bulged out. And then take a look at the other side here as kind of a reference to see. And don't forget, you have this nice little optic nerve running through here, trying to get through here. And then that's really the key to this, why we want to diagnose it. And here is a picture from Elsevier 2005. Give them credit. And you can see when they put this picture out, you can see how the muscles have hypertrophy. Imagine that eye being in an orbit, and the only opening is towards the front. So which way does that eye go? But don't forget, what's running through this muscle cone is that optic nerve. So ischemic compressive optic neuropathy is a huge, huge concern and scare. And that's why you need to know where that orbital disease specialist is located so that you can find that person. So here's exophthalmometry. Do I do it on every patient in the practice? No. But what patients do I do it on? The patients that come in and they're autoimmune and They're obviously on synthroid, autoimmune, and it doesn't really matter if they're hyper, hypo, or euthyroid. Now, if the patient had a pituitary adenoma or a thyroid cancer, so they had thyroid cancer, radiated, had their thyroid removed, again, it's not antibody related. Pituitaryectomy from bitemporal, hemianopia, you picked it up, so on and so forth. I probably back off on those in my practice. So it's really the autoimmune that gets a Hertel or Ludi measurement in the practice. And here are the concerns: 2 millimeter difference between the eyes and a measurement more than 24 millimeters. And that's why I give you the handouts or the whole presentation, because you can reference it. You can see it is race dependent, Asians versus blacks versus whites, and you can see the upper limits and what the concerns are. So restrictive myopathy, right? We're starting to now get into double vision. I don't know why the inferior rectus is the most commonly involved. I've tried researching it. Sometimes you can just find things out, but it's just maybe it has the more receptors on it. More looks like thyroid tissue, but it's the one. But they all can be involved, as we saw. But the key is now these patients can end up with double vision, and it can be permanent. And we're going to talk about getting them to an adult strabismus doc here in a second. IOP and thyroid, we're going to talk about that here. I have a bunch of pictures coming up, probably in about 8 or 9 slides. So here's the classic case of a patient that comes in. Look at the restrictive myopathy. And this one was kind of missed for a while. A lot of people couldn't solve this one in a sense. It's easy when you're sitting in a thyroid eye disease lecture to identify, oh, yeah, take a look at this. They have some periorbital edema. They've got the inflammation. They've got the eye turn. Oh, it's quite obvious that it's thyroid eye disease. Drop this patient into your 25 or 30 patients, or 10 or 15, whatever you're comfortable seeing in your practice. And it starts, patient after patient. It could be maybe not so obvious. But you can see the restrictive myopathy, again, the double vision, the periorbital edema, and the inflammation that's causing this. And again, the other part could be that it's confusing. We talk about 7-to-1, but you can see here, a lot of my cases that I have presented here unravel. You're going to see a bunch of males or men, and that's because I think we kind of tag this as a female condition, but it can affect the men too. My guy that walked in, I'm showing you this person, and I got some slides here towards the end. Cornea exposure, we're optometrists. We know how to treat lag ophthalmos and cornea abrasions. Here's the key. Another important part is that's at 5% of patients, usually mild to moderate exophthalmos, shallow orbits can lead to a compressive optic neuropathy. And that's the reason why, again, I always tell docs when I do my lectures, ask your pharmacist to keep 1% atropine in, keep Zirgan in stock for you. Those medications in case you have to treat an iritis and so on and so forth, or Zirgan in case you have to treat a herpes keratitis. But know where your orbital disease specialists are in case you have to get someone down there, as you'll see a patient here towards the end that we tried with the rheumatologist, but we didn't like the response, so we got them quickly to the orbital disease specialist. So treatment of thyroid eye disease, it depends whether they're in that active or inflammatory phase or moving into that plateau or resolution phase. Depends on the orbital tissues and structures involved. Do we have to get an orbital disease specialist if it's a little bit of edema and lid retraction? No, but if that orbit is becoming congested and an optic nerve is at risk, now we have to move into maybe an orbital disease consultant. Management consists, it's an inflammatory condition, right? So we're going to be using lots of anti-inflammatories along the way. Education is essential, and communication with the endocrinologist and internist, because I can't tell you how many times, what the hell is Dr. Caldwell talking about? Your thyroid's perfectly fine, T3, T4. You're going to have to make a phone call, right? You're going to have to educate. And sometimes that phone conversation is 10 or 15 minutes because you kind of have to teach them about these thyroid. They know about it, but oh, is this, I get it. It's receptors, it's this and the orbit. Oh, it's going to kind of have to be a little reminder for them. And it's not the T3, T4. And that's why they're having these issues. And why are you sending them to a rheumatologist to get treated? This is an endocrinology problem. So that's why I said this is one of my funnest lectures to give, to really empower the optometrists out there to really solve these cases and then get the patient to the proper doc to be treated. So when it comes to treatment, it's in these in the treatment of thyroid eye disease, it can be palliative. It could be steroids. In an active phase, it might be radiation. In a passive phase, we might be sending this patient for fat decompression or bone decompression. And that's what the orbital disease specialist comes into play, because that's who does these types of treatments and deciding, okay, and you're going to be a part of this, helping to decide, are they active, passive, resolution, reviewing records, knowing symptoms, and talking to the patient. With any autoimmune disease out there, doesn't matter if it's thyroid or Sjogren's or mixed connective tissue disease, whatever it is, the patient has an abnormal immune system, and it's responding to normal tissue. And then the patient is smoking, and they're adding all these toxins to their body, stressing their body, more oxidative stress. I can't tell you how I get into my patients and ask and beg them if they're still smoking. You can smell it when they come in. Oh yeah, I quit. Okay, then my smeller's not telling me that that's what has happened. Can we please, because this type of autoimmunes and the oxidative process is not good if you're a smoker. It's not good for anyone, but it's especially if you're autoimmune. So now that we understand this, there's these paradigm shifts that are occurring out there. So what's the treatment when we're talking about lid retraction, eyelid, lid lag, lag ophthalmos? Again, it all depends whether they're in that active phase, what we're talking here. You need kind of handhold them. You're treating the exposure keratitis. You might be doing lid taping, lots of treatments out there, steroids. In the passive phase, we might be moving into surgery, oculoplastics docs, and moving into maybe some orbital disease patients to kind of get these patients treated, or even adult strabismus docs. Just like this patient here. And this remember this slide so I don't have to click back. In about 4 slides coming forward. Take a look at this patient. This patient comes into my practice and says, hey, doc, I want to come see you guys. I just moved to the area. And yes, I have had thyroid problem. And that's why my eyelid looks like this. And, everything seems to be fine. My T3, T4, and, maybe they even said, oh, my antibodies are good too. But my point is that this patient was so well versed and so burnt out into the resolution phase. Then why aren't we fixing this upper eyelid? Well, I was told that nothing could be done. Well, let's get you down to my oculoplastics guy that's down, 40 miles away from me, and let's see what he has to say about this. And you can see this patient is much happier going through life now with not having to explain why the eyelid is in this position every time they go somewhere or meet someone. Here's our patient that we saw earlier, and we saw this patient a little bit earlier, is that this is the periorbital edema, the inflammatory conjunctivitis. So obviously it's going to be steroids, maybe Restasis, Xiidra, Cequa, these anti-inflammatories or immunomodulators, ointments at night, steroids. We might have to move into diuretics or oral steroids, getting the rheumatologist, in my opinion, or your primary care doc involved to administer some oral steroids. We can do it as optometrists, but when you start getting into, in most states, but when you start getting into IV steroids or periorbital injections, now we're making referrals to help these patients. Here's that orbital disease consultant I've been talking about, getting them there for systemic steroids, low dose radiation, or optic nerve decompression. And then, we as optometrists know how to handle double vision, but there are different ways out here when it's thyroid eye disease. but then we might be in the burnt out phase. We might want to recommend, hey, let's get you to an adult strabismus doc that maybe feels comfortable operating on someone where there's some scarring going on, and seeing if they can have you become more binocular. And then I can do things with glasses, with less prism, or even Fresnel prism. I do that sometimes. They go get the surgery, and instead of making it in the glasses, maybe because it can change, we can put Fresnel prisms on. That's a lot of what I do when managing the double vision with these patients. Cornea exposure, we know how to do that. I want to kind of focus on this optic nerve right here. This compressive, this type of optic nerve problem, or this ischemic type of optic nerve. You can do methylprednisolone, you can do radiation if this is an active phase, or you can get into orbital decompression with fat or bone. And the doc that I work with, he sent me this slide, and you can see that where the copyright is here. So he sent this to me and said, hey, doc, take a look at this. If you do a 2-wall decompression, you can get up to 6 millimeters of retrodisplacement, anywhere from 3 to 6. If you do a 3-wall or a 4-wall, check this out, anywhere from 3 to 16 millimeters of retrodisplacement. Obviously, we start with the superior because it's the thickest, and we end with the last one being the inferior, because we all learned in school that inferior orbit is the thinnest, and that's why people end up with blowout fractures. But you can see superior, nasal, temporal, and inferior, anywhere from 3 to 16 millimeters of retrodisplacement. So finally, Joe, I get a little break here, is we get to launch polling question number 4. And if you can take care of that for me, that would be great.
Okay, I'm going to launch it. As optometrists, we can help someone with his or her depression and anxiety.
And I think that's a true or false question, right?
It's true or false. And I think we're pretty well. This was probably the most skewed one I've ever seen. Everybody said true.
Great.
Oh, somebody changed their mind. So hopefully everybody's seeing the polls. Just go over to the icon for polls if you haven't seen it yet. Well, far and away, we are all agreeing that this is a true statement.
Great. So I'm going to come back to these pictures, but let me go to this question. Let me go to this one first. And we're not going to say it this way, but check this out. This is a person that obviously has thyroid dysfunction, soft tissue involvement, upper lid retraction, redness. So this person walks in and they say, hey, why are my eyes like this? And you say, hey, your facial disfigurement occurs because you have thyroid eye disease. And there are studies, and you can go to PubMed and look them up, but there are studies that show that this is like telling the patient that they have cancer or AIDS. So I have seen patients come in on anti-depression medication, and they wonder, people are always asking me, why is your eyelid up here? Why are your eyes bulging? So on and so forth. People are on antidepressive medications. And you say, look, we can get you to an orbital disease specialist, or not an orbital disease, but an ocular plastics person here. And they can really, take and reconstruct these lids, or at least get a consultation if they don't think they can have it, and take a look at the before and after of this lady. And on this picture here, she's not on any antidepressive medication. You can see she's even got a little smile. You can see a little happier. Hair is a little bit different. She's feeling good about life. She's feeling good. And it came from the optometrist here, just kind of coaching her as she came in for her eye exam. So you can see when this occurs that it's equivalent to the diagnosis of cancer and AIDS. And here's a patient that was at risk with that optic nerve, so went through a orbital decompression, and you can see how that eye has now, and that nerve is at less risk of having any issues. So now let's talk about that IOP and thyroid. So if someone comes in and I see that they're on Synthroid and they're autoimmune, do I really throw them to any risk of primary open-angle glaucoma? And the answer is no. But maybe a secondary type of glaucoma, if that's what we want to tag it. Like this person's periorbital edema is probably not enough to really influence the IOPs. But this person's amount of inflammation and amount of swelling, if you maybe check their pressures, it might be slightly different than what it was when they didn't have all this inflammation. And this patient here, or this IOP on this left eye, might not be the same as this IOP in the right eye. And here's a patient that their IOPs, or we saw this one earlier, as this patient is trying to get rid of that double vision and the fibrosis and the amount of scarring that's there, you might see an influence on that IOP. Joe, I know that you do a lot of glaucoma, and that's kind of your specialty out there. When you have a patient comes in and you see them on that's thyroid, do we get concerned about, oh, you're at risk for thyroid? Is this more of a secondary type of action?
More secondary. We always have to be careful of the elevating IOP in a person with thyroid disease, particularly if you can actually see, something similar to what you're seeing there, because there's only so much room in the orbit. But Greg, I'm just going to take a step back. I didn't interrupt your momentum earlier. You're talking about compressive optic neuropathy.
Absolutely. Go ahead.
Everybody worries about compressive optic neuropathy and tumors. And they always worry that their glaucoma patient actually has a tumor. They think compressive optic neuropathy, something in the orbit, tumor. The number one cause of compressive optic neuropathy is thyroid disease. It's Graves' disease. So that you're not just considering looking for tumors. You need to consider that it's the muscle bellies in a patient with thyroid disease and Graves' disease that's actually causing the compressive neuropathy, not really a tumor.
So out of all the different types of optic neuropathies that are out there, when it comes to, I guess, in a sense, a compressive, thyroid is leading the cause. Is that a good way of, there's toxic optic neuropathy and so on and so forth. So
in terms of compression, it's just not an orbital tumor or a retrobulbar tumor. It's thyroid disease is number one cause of compressive neuropathy.
Yeah. So it's great, and that's why it's great having Joe on these types of webinars, because I'm not sure if everyone's aware that Joe is chair of the Academy, but Joe is definitely my phone a friend when I have anything in neuro. So thanks for bringing that fact up, Joe. Thank you.
You're welcome.
So laboratory tests here within thyroid. These are just in your handout just for completeness. These are the thyroid hormone levels or testing that you can do. And right here is the key. I told you you'd be sick and tired of me saying antibodies. This is really where I live my world in getting this test. I really don't go down here and get T3, T4, calcitrin. That stuff can all be pulled up online. The patients usually can do it on their cell phone. If they have an iPad in the office, they can pull that all up. They very rarely have these tests done, and that's what you're ordering. And then sometimes, you'll be like, oh, in this era of healthcare, and we're trying to, not have waste. Why does this optometrist want to order these? Well, it's because they've been having eye problems for the last, 18 months. I kind of want to see what their antibody levels are. So hopefully you got a good flavor of that tonight. And this is all the things that we've been talked about that happens in hypo and autoimmune atrophic, and it's just in there for completeness. Now here's a patient that again, a male patient. Remember, this is supposed to be 7-to-1 females, but here is a male patient that has thyroid problems. Again, in a thyroid eye disease lecture, it's pretty easy. But this is a patient that walked into my office after being at an ophthalmology and ODMD practice and said nothing else can be done. Obviously the PCPs don't want to, steal patients and refer patients, but he walked in and said, hey, look, nothing can be done here. And I'm just, I think something can be done in today's technology. So they was like, hey, go down and see Greg and his practice and see what they did. And the best part about this whole diagnosis is my technician walks out and goes, I think he has thyroid eye disease, but, I'm not sure. You're the doc. That's just my condition. So that was her opinion. So as we look at this patient, my concern now is you can see all the periorbital edema. You can see all the redness going on with this patient. And I have video, but I don't think it's embedded into this presentation. But look at this eye. He's got restriction. He's having some congestive issues. And as Dr. Saka mentioned here, I'm starting to get concerned. And now I'm even more concerned knowing that it's the number one cause of compressive optic neuropathy. And so we can see here, I'm just trying to give you some more videos of what it looks like. The periorbital edema, redness, worse in the left eye than the right eye. And so we started him on some oral steroids, some topical steroids. I called up the rheumatologist and said, hey, I'm going to need some help with this. He's probably going to be long-term. Okay, Greg, prescribe this and we'll do some follow-up, so on and so forth. But over time, you can see the edema goes down. He's starting to look a lot better. Let's go back a couple slides here to kind of remind us what it looked like. And he's starting to look better. You can see the edema starting to drop. And this is 4 days later. But he still has this double vision. And he's still a little bit red over here. And I'm still concerned about this left eye. And you can see, again, he's looking better. But I'm still concerned about this left orbit. Here's April 22nd. He's starting to get a little red again. Double vision, not liking it. This inflammation, concern about this optic nerve. And we sent him down to the orbital disease specialist. And I just spoke with them. I've been out of the office for about 4 weeks, just been traveling, and I had to sit for a week because of COVID. I was tested negative, and now I'm allowed to go back tomorrow. But right before, we did call him up and said, hey, what's going on? He is going to come in for follow-up. So I have some follow-up questions, follow-up pictures, because we kind of lost him for about a year there. But he did see the orbital disease specialist. He seems to be doing pretty well, but he did have some surgery done on this left eye. And I'm glad, because we learned tonight it's the number one cause of compressive optic neuropathy. Joe, you want to launch polling question number 5?
Surely. Which biologic pharmaceutical is recently approved for the treatment of thyroid eye disease? Oxervate, Humira, Biovu.
And teprotumumab is the next one, and
you name it, Izumab.
It's one of those immunomabs. But teprotumumab is number 4, but that would be Tepezza. I don't think I typed in the brand name.
Just remember, if you see it advertised on TV, you can't afford it.
Mm-hmm. So all of these biologics are used in the eye. I think I don't have the polling question up, but I did enter these. But Beovu, I think Oxervate is there, Humira, and teprotumumab as Tepezza. All of those can be used, but which one is for thyroid eye disease?
Yeah, the number 1 is Humira.
All right, great. So let's jump into here. And thyroid eye disease therapy shows, and I can't see where the date, here it is right here, December 2018. As you can see, Primary Care Optometry News, I just kind of took a screenshot of this. It's talking about teprotumumab, this IGF receptor antibody. I was real excited about this. It's through Horizon Pharmacies. They were talking about these phase 2 trials. And just to kind of get you up to speed, March 20th, March of this year, it was approved. I think it was set to be approved within when you work with pharmaceutical companies, they always get excited about their PDUFA date. And I'm not sure what the acronym is, but basically that's when it's going to be reviewed by the FDA to see, they're going to look at the phase 1, 2, and 3 trials, and then they're going to see if they can bring this to market. Well, this came about, teprotumumab. These letters really don't mean anything. It's all for a registry, in case you guys want to know why you see these. Some biologics don't have it. Some do. The older ones don't. It was, again, because you can't really make a generic, but you can make a biosimilar. So that's why they have this out here. But Tepezza is now the brand name as it became approved in March. Really cool, because I think my rheumatology doctors are going to be the infusion site for this. There's only one out there that we can use it in a sense as a biologic, as an optometrist. That's Oxervate. It comes in a glass bottle and pipettes and so on and so forth. But Horizon Therapeutics, this is a human biologic. I won't get too deep into this. We do have a 2-hour lecture on that. It's infused 8 total every 3 weeks, but it's a receptor inhibitor monoclonal antibody. So it's actually targeting this inflammatory pathway. Really cool, really excited from a geek here that we can, in thyroid eye disease, that we can get these patients treated. This gentleman right back here with it would earlier in disease, and now the studies are showing you can even do it now, he would still benefit. But catching him earlier and intervening with teprotumumab or Tepezza is really a great way to do that. So be aware of this out here, look for it, and if you have patients that are having thyroid eye disease, maybe find out where the nearest infusion site is to get them treated. Really cool stuff that's out there. So Humira is used to treat a lot of eye disease. It's approved for uveitis, mainly posterior uveitis, and has a few other. So I like the answer Humira, but teprotumumab is probably the better answer. So Joe, go ahead.
Yeah, I mean, and that's power of advertising. I would have answered Humira as well, because that's the one I have most recognized from advertising. Yeah. Greg, a question came in, and I apologize I didn't get to it at the right time, but what is recommended for taping the eyelids closed at night? This comes from one of our audience members.
It just says what is recommended to do it. Is that kind of the question? Is that how you're reading it?
Yeah. Do we do it, and how do we do it? What's the best way to do it, I think? So why don't we answer both of those?
Yeah. So, obviously it's a patient that typically, obviously has lag ophthalmos. It could just be, it could be from a neurological. Let's say it's not in this case, but from a Bell's palsy, right? So we just use some tape, transport tape, or even the cloth tape. And what you want to do is just kind of teach them, or teach their significant other how to kind of get the eyelids closed and tape it. So just cloth or transport tape. Sometimes I'll do a little tape torsorrhaphy, put a little bit of tape in the on that superior lid crease, and it kind of paralyzes that lid a little bit, and then put another piece of tape over it to kind of keep them taped at night. So we just kind of demonstrate in the office, anything fancy, just transport or cloth tape. The tape that you see them use. And I guess in eye surgery, if they put an eye shield on, just kind of that tape.
Excellent. Thank you, Greg.
Yep. Any other questions?
No, not right now. We're doing well.
Okay. So this slide, before we move into rheumatology, is it was being a geek, and we pull all these references, and I couldn't believe how many signs there are of thyroid eye disease. So if you guys want to play Trivial Pursuit just within thyroid eye disease some night, take a look at all the different signs that are out there. So that was kind of funny. So we kind of took care of the questions. Let's take care of polling question number 6 here, Joe. And I think, what do I have? About 20 minutes here, so maybe 25 minutes. We won't get through all the rheumatology, but maybe in about 10 minutes I'll get to the end and maybe show people how to look for Plaquenil toxicity, since Plaquenil and hydroxychloroquine have been in the news. So.
All right, well, poll number 6, rheumatology and the eye. Guess what is similar? Antibodies. Patients complain about copay, or TRH, TSH, T3, T4 is important here in rheumatology.
Kind of a question, I think, with an obvious answer, a funny answer, but just kind of a reminder. that the similarity now between thyroid and rheumatology.
Mm-hmm. And as would be expected, the leading answer right now is antibodies.
Great, perfect. And that's kind of the bridge we wanted to make. And the funny answer is people complaining about the copays. So thanks for everyone for bearing in and doing that poll. So thank you. Thanks, Joe, for doing it. Mm-hmm. So rheumatology specializes in the diagnosis and therapy of problems involving joints, osteoporosis, skeletal muscles. And again, I have the privilege of working right down the road from an 8-man woman rheumatology practice. And working with them, they talk about the 200 types of diseases that are within their specialty. Because as we all know, it's just the eye, but well, within the eye now we have cornea guys and glaucoma guys and scleral contact lens and low vision. You get to one organ and the eye, and it has all these kind of specialties. How about rheumatology taking care of the whole body, over 200 types of diseases involving. But the key to rheumatology is, where does everything overlap? Connective, where does the eye and the rheumatology connective tissue, the vasculitides, I kind of break it down into these kind of components for the eye, and the spondyloarthropathies out there. Where do they kind of cross over? Well, when we talk about connective tissues, are composed of lots of other things out there, but the two major proteins of connective tissue is what? Collagen and elastin, right? Back in the day when we went to school, I know Joe and I, we are not that far apart in graduation, but I know when we went to PCO, we were taught about collagen vascular disease. Well, it's an antiquated term. These are connective tissue diseases now. So if you're still using collagen vascular, it's okay. You know what they were referring to. But when you talk to the rheumatologist, refer to them as connective tissue diseases. Now, how about this? How many times did you think that when you were going to go to practice that you were going to see a patient with Marfan's or Ehlers-Danlos, right? Every day of your life, you're going to see someone with this type of connective tissue because it was beat into our head, long, tall, Abraham Lincoln, how the heart and aorta and how the lenses can sublux and so on and so forth. Very important to know, but what's the difference between this connective tissue disease and the ones that happen in rheumatology is that these are chromosome deficiencies, right? These are chromosome gene abnormalities. This has nothing to do with that word that you're hearing sick and tired of me saying, antibodies. When it comes to autoimmune, the connective tissue secondary to autoimmune, these are not really generated by genes. It probably is somewhere along the line. There's a gene defect, but it's not these chromosomes that we see with, in a sense, with Marfan's and Ehlers-Danlos that's out there. So when we talk about lupus and rheumatoid arthritis and Sjogren's and systemic sclerosis and polymyositis and mixed connective tissue, these are all autoimmune. And look what the rheumatologist orders right here, all these antibodies that they're testing the patient for whenever they're trying to make the diagnosis. So if you look at connective tissue, and it's made of two proteins, collagen and elastin, if you just look up the definition of sclera, it's the opaque, white, fibrous, protective outer layer of the eye containing collagen and elastin. And if you look up synovial membrane, right, that's the membrane that's in our joints. And when we crack our knuckles and the fluid kind of shifts to the side and it makes that loud cracking noise. Well, the synovial membrane is a connective tissue that lines cavities, joints, tendon sheaths, bursa, and makes the synovial fluid, which is the lubricating function. Now, does the eye have anything that's equivalent? I'm going to pause, let you think. And the answer is yes. We just don't call it a synovial membrane. Dr. Tienan gets it named after him, but Tienan's capsule is nothing more than, think of the eye. It's a socket. It's an eyeball that moves in it. It's a special joint. And why would it not be affected by all these other conditions in rheumatology? And it does have its own synovial membrane. We just call it a Tienan's capsule. And when you look up that definition, it says it's a membrane that envelops the eye from the optic nerve to the limbus separating it from the orbital fat and the socket. But what is it? It's a connective tissue. And if your body is making antibodies to attack connective tissues, the eye certainly comes into play, and that's where these antibodies come into play. So, here is a patient that's 53 years old, referred for a red left eye. 3 weeks ago, sudden onset. I'm going to go through this case pretty quickly because this is kind of a rare case. We're not looking at these conjunctival vessels. We're looking at this episcleral vessels, and she has an episcleritis. She fills out her review of systems when we were paper, and she reports that her knuckles are inflamed. And we talk about which knuckles are inflamed, and it's these ones here which have a high incidence of being affected in rheumatoid arthritis. So I placed her on some Lotemax, some ibuprofen, 400 milligrams. My pearl when treating an episcleritis is treat it topically and treat it orally. Use over-the-counter ibuprofen, 400 milligrams, 4 times a day. Just so you know, you're allowed 16 pills a day. You're allowed 3,200 milligrams of ibuprofen. 800 milligrams 4 times a day, that's prescription strength. So that's why this is half the dose. You can do 400 milligrams. You're treating the inflammation of this, and along with using the Lotemax, you'll have a lot of higher success rates in treating your episcleritis. You educate the patient on the findings. She reports that there's an uncle out there. He's never really had any diagnosis. He's one of those guys, I don't believe in docs, but his hands are almost crippled. So what do we do for as a test? Well, now what I would do is I would send the patient to the rheumatologist, but back in the day, I was ordering blood work. And so I ordered an anti-nuclear antibody and a rheumatoid factor. You can see not the best picture, but it did clear up nicely. And we weaned her off her drops and her ibuprofen, and I reviewed her blood work. And you can see here that her anti-nuclear antibody was negative. But when we looked at her rheumatoid factor, it was elevated, it was high. So this was enough with her knuckles being inflamed and that being that we got her over to the rheumatologist, and the rheumatologist diagnosed her with rheumatoid arthritis. Now, why this is kind of a rare one, most episcleritis are idiopathic in a sense. They're really not related to systemic disease. But episcleritis, its vessels are movable. They blanch with sympathomimetics. That's the conjunctiva. The vessels are movable, and then the episcleral vessels don't move. And the key here is simple episcleritis, nodular. There's just different names that are out there, but most of the time it's idiopathic. But when it is associated, it could be allergy, it could be medications. This is one of the things that we talk about, one of the other docs that I lecture with. We talk about how osteoporosis medication has these biphosphates, phosphonates can have, like Fosamax can create episcleritis uveitis. That's one of a side effect. Idiopathic, or it could be these kind of autoimmune conditions that are out there. Now, we're going to go through this case a little bit quicker because this is the opposite. This is the easiest thing for me to treat when they come into the office now. Here's a 48-year-old woman that comes in, and she says, my eye is just killing me. It hurts like crazy. Boom, we've got a scleritis. Deep, you can kind of see that it's kind of elevated here, maybe even that blue hue. Nice, painful eye scleritis. Scleritis comes in many flavors. There's non-necrotizing scleritis. But when I say it's easy, it's probably related to something systemic, some systemic disease. And I don't really want to mess up the blood work that my rheumatologist is going to do. So just like whenever we refer a macular on detachment to the retinologist, they'll see them in 24 hours and usually do surgery. When I call my rheumatology group up and I say, hey, can you do me a favor? I got a scleritis over here. Yeah, we'll get them in within the next 24 hours because they know they're in a lot of pain. They know that they need a blood workup. It's probably related to something systemic. And so they want to get the blood work before we start intervening with any type of anti-inflammatories that can throw that blood work off. And I think we all know the symptoms, the signs and symptoms: deep, boring pain, that it's just, a lot of times they just come in and they're just holding their eye. I'm not sure if it does anything, but it just tells you how much pain that they're in from this scleritis that's out there. And remember, there's anterior scleritis and posterior scleritis, and then there's different types. And now think of these necrotizing with inflammation, necrotizing. And what is happening in these patients is that they've had so much inflammation. It's kind of like diabetic retinopathy when they start getting capillary shutdown in the end stages. These patients have been so inflamed, so long, maybe not treated. Maybe they just didn't go into the doc, but now they're getting capillary non-perfusion. And that's the non-necrotizing. They're well perfused. And then when you move into the necrotizing, the inflammation, it's almost kind of like cornea melt in some of these patients. You put a steroid on, even if you put them on steroids, that sclera starts to thin. You're getting capillary shutdown, or in this case, you could see the conjunctiva type of necrotizing and the scleritis. You could just see that there's no blood vessels in there, and it's just creating this necrotizing issue where we all have gone to school and seen these pictures of the sclera thinning, and it can lead to a choroid rupture, or the eye might rupture and the choroid comes through. And then this is the scleromalacia perforans that we've all learned about. Posterior scleritis is the only one I've seen in, I guess, 25 years, and it happened to be when I was a resident at PCO, and that's the only picture that I have. Luckily, I haven't seen it since, or at least I don't think I've seen it in my care. But how it's usually diagnosed is through a B scan, and that sclera being extremely thickened that's out there. So, scleritis is pretty easy when it comes into the practice, because what I want to do is make sure that I get it off to the rheumatologist. And the key here is that scleritis doesn't really respond to topicals. Topical steroids and NSAIDs are really ineffective. You're moving into oral non-steroidals, ibuprofen or indomethacin or oral steroids or even IV. And that's why, again, it's off to the rheumatologist. One, to probably start them on these IVs or on these oral steroids, but also to get the proper diagnosis. I can certainly start them on oral non-steroidals and oral steroids in Pennsylvania, but then it just messes up the blood work. And that's just working as a teammate. Now they're going to send them back because they're going to want to report on how they're doing and what's the eye signs. And you see that scleral thinning, but they're going to be probably managing this patient from a systemic disease rather than me treating the ocular. Maybe I will add a topical steroid, but the key is getting them to the right teammate first in this condition. So, rheumatoid arthritis is associated with a lot of scleritis. It's 1% of the population. Again, women more than men. You can see the age of onset that's out there. Again, it's an autoimmune disease, and this is the antibody that's typically this anti-rheumatoid arthritis 33 antibody, but there's a whole other list of antibodies that are out there. Now, rheumatology is tough because luckily as optometrists, we're kind of more externists, right? We get to see the cornea, we get to see the retina, we get to see the lens. Oh, you have a cataract. The rheumatologists are a little bit tougher because in making diagnosis, because they're internists, right? They're constantly looking at blood and looking at x-rays. It's everything that's happening internally, listening to the breathing, listening to the lungs, the heart, and the joints, and how are things. And this is how rheumatoid arthritis is diagnosed, is they have this list of 7, and criteria 1 through 4 must be present continuously for 6 weeks. And then they can have parts of these others. So really 1 through 4 for 6 weeks, they're doing blood work, and then they're evaluating the patient. And remember, I mentioned before about this fusiform synoviitis, that it typically attacks these joints right here in rheumatoid arthritis, and that's what was happening with our patient with the episcleritis. And really, this is the key. We want to get the patient diagnosed early, and with all these biologics, try to treat them here so they don't progress into something severe or intermediate or late, so that they can open a jar, that their quality of life is not compromised by the rheumatoid arthritis and the beauty of all these different types of biologics that are out there. Vasculitis can occur, and here's some vasculitis and capillary shutdown that you can see happening with this patient. And here is some necrosis that you see. And again, you're trying to keep the quality of life for the patients at a high level. And that's when you hear these disease-modifying anti-rheumatic, these DMARDs with methotrexate. And here it is, hydroxychloroquine, Plaquenil, and these different types of medications, even minocycline as an anti-inflammatory, or moving into the biologics. And there it is, Humira, which is used in rheumatoid arthritis, but also a few other eye conditions recently approved with posterior uveitis, having an eye condition, and you can use it on label for that condition. And there's Remicade and Enbrel that's out there. Joe, any questions that have popped up?
I'm going to look right now, Greg.
Because I know I have about 5 to stay COPE compliant. We did probably start at about 3 or 4 minutes in. So being that COPE has been nice enough to allow us to do all this, I'd like to be in regulation. But if there's no questions, I'll go through this, and I'm going to jump to my Plaquenil.
No, there were just a few comments about the poll. I know people were responding to the poll, but I think some people were not seeing the poll. That might just be a webinar jam sort of issue, but no questions right now.
Okay. And just so people know, you'll still get credit because we can tell through the programming when people log on and log off. So there's just a few things that we just turn in. So if you don't do a poll, that's okay. If you answer, if you make a comment in the chat section, everything's fine. So, all right, let me do this quick case, and then I'll move into the Plaquenil. And this is just really a fast case that I'll go through because I want to make one big point out of here. Here's a 45-year-old woman. She's saying that she has something in her eye, but it moves when she moves her eye. It's not like a floater. So here's the key is we got this white spot here, and we have this white spot here. This is a cotton wool spot. And most of us have been doing for years now wide field imaging, Optos, and there's other types of instruments out there. And we find retinal hemorrhages all the time. So the key was when I started finding all these retinal hemorrhages, that we work them up and we didn't find anything. We monitored them, they go away. And then if they had some other symptoms or if they had any other eye signs, maybe now we work them up depending on what we find. So every retinal hemorrhage I don't work up. But take a look here. Everything looks good other than this patient has 2 cotton wool spots. When you see cotton wool spots by itself, a bell should go off. Whoop, 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 because this here is showing that they have ischemia at a high level. This should not be happening. But hey, look, the retina looks great. I don't care. A cotton wool spot is a red flag. It's worked up. Internist, yourself, rheumatologist, get them worked up. This is not diabetes. This is not high blood pressure. I'm going to skip forward. This is diabetes and high blood pressure and a cotton wool spot. This is not. This needs to be worked up. And here's your non-specific findings. Hypertension, diabetes, connective tissue. A lot of the times it's blood dyscrasia, anemias, leukemias, vitamin deficiencies. My point is when you see a cotton wool spot, please work it up because there's probably something going on. We all have wide field imaging. We're doing it now, or most of us have it. We're doing it, taking pictures. It's part of a wellness exam. When you see it, please work it up because it's not going to be diabetes or hypertension. It's probably going to be something else. So this patient got worked up. They had anemia. They have a SED rate that is high. Check this out. The ANA. Ask yourself, wow, look, it's only 1 out of 164 and it's a speckled pattern. Is that high or low? Ask yourself if this anti-nuclear antibody, is it high or is it low? And I'm going to answer it for you. That is bad. That's not a good sign. Here's how you read these ratios. It's the ability to dilute it and make it undetectable. So if I was at a meeting and I had some water sitting there and Joe was being a little bit, trying to rib me a little bit and put a little bit of salt in my water, and I drink and go, ooh, there's salt in there. I can pour a little bit of water in there and dilute it out, and then I don't taste it. But if he put 2 or 3 packets in there, it's going to take more of diluting it to get it down. And that's what an anti-nuclear antibody is. Anti-nuclear antibody, it can be normal. Some of us can have it. But whenever they go and they do the blood work, what the lab person is doing, it keeps diluting it and doubling it. That's why you'll see 32 and 64, and it keeps doubling. And it keeps doubling out until they get a negative. So what it's saying is that it took 640 dilutions to get that to be where it wasn't found. And that kind of tells you that there's a lot of antibody in there. So this is a very high positive anti-nuclear antibody. And with the fast forward through this case, this patient here ended up having lupus and a diagnosis of lupus. So, the key here with this last case that I wanted to review is make sure that you work up your patients that have cotton wool spots. I see it missed a lot by optometrists. Even early in my practice, when we were doing wide field imaging, docs would be like, oh, it's just a cotton wool spot. We'll just have you back here in a few weeks and see if it goes away. Well, it's probably going to go away, but you want to make sure you try and catch the systemic cause. It doesn't have to be lupus. It could be a vitamin deficiency. It could be an anemia or leukemia, but please work up those patients. And these are all just a little bit of findings that you find with lupus that are out there. You've got the rashes, you got the discoid lupus type of rash, the cutaneous manifestations. You can get the butterfly rash on the face. They become photosensitive. But you can see here, you can see the interarticular dermatitis. But you can get the retinal vasculitis, and this is what they're talking about, the cotton wool spots that can occur. So obviously systemic lupus is, or I say obvious, but it's treated by a rheumatologist, and they're going to get them on biologics, DMARDs, use sunscreens, and the avoidance of sunlight. And again, here's that same list that's out there of the different treatments that's out there. And Joe, I'm going to pause here because I think we're probably getting close to the time limit, and I don't want to extend or wear out my welcome that's out there. So are there any questions, or do you have any comments with any of the stuff that we've talked about?
Well, I'm going to look for any last minute comments or questions. Okay. Well, here's one that comes across. I think it's an interesting topic. How much of the retina needs to be photographed for it to be considered a wide field view?
Do you have any comments on that?
I don't have a comment. I don't think that there's criteria, but I know most of the imaging devices do 200 degrees. And that's about 200 degrees horizontal. Here's a question. Patient with Hashimoto's for 42 years, late now. Also lupus for same time frame. Past seven years, diplopia in the morning goes away with blinking. Past week, constant. Thoughts?
Well, one of my thoughts, if it's kind of intermittent and coming and going, I would think in another type of condition would be myasthenia gravis. That one certainly kind of becomes part of it. But once that's kind of ruled out, then, obviously it could be part of what was the conditions, lupus.
And Hashimoto's disease.
Yeah. So, you have 2 autoimmunes going on there attacking the eye and the orbit. So that certainly could do it. But if it's intermediate coming and going, how old was the patient?
It doesn't say, but he's had the disease for 42 years.
Yeah. So it's kind of older. I would also, I don't think, it needs to be automatically worked up, but don't forget about Graves' disease that's out there.
And also, when you have these patients who are diplopic or ophthalmoparetic, don't forget, whenever possible, do the force duction test. That will tell you if we have entrapment of muscle or is it infarction or affect the nerve? So I think with that, we're about at our time, Greg. So why don't you just wrap this up and bring it on home?
Yeah, I just want to say thanks. You can put some more questions in there to make sure that we keep to the right time limit. I'm just going to remind everyone while we're seeing if there's any last questions to roll in that this was recorded. It will be on our YouTube channel for you to rewatch it. Vanessa will get everyone who attended tonight, those who are here for credit. I do know there's some people in here that just wanted to listen. Thank you to those people. But Vanessa, for those who need credit, we'll get her the people that need that. It will get uploaded to Arbo. Please give Arbo 7 to 10 days to turn that around. With all the webinars out there, it's just they're just drinking out of a fire hose, from lack of a better. And then we'll send out a letter of certificate to you. For those that are not Arbo states, you'll get a certificate from us, and you'll have that for your records. So I just want to say thank you. I hope you learned something from the thyroid part tonight. I really think that that's really the key of in optometry is really don't. I hope you learned enough to feel strong when it comes to working and discussing with the PCP and endocrinologist, because they're going to be like, hey, they're T3s, T4. You sure you're going to call this thyroid eye disease? And hopefully this arms you enough and empowers you enough to be able to do that.
Hey, Greg, there is one last moment question. And the question is, what thyroid test should be done if a patient has a suspicious refractive change?
What thyroid test should be done? I guess you could do the whole, if you're thinking thyroid, and you can do T3, T4, TSH, and then get the antibodies. I don't see much refractive shift with thyroid. And not to say, it's not rare if it's in your chair, but if you're going to do some blood work, you might want to do the realms of maybe a hemoglobin A1C, and a fasting blood, along with a complete blood count, if you're going to do that. But what I've learned nowadays is with all these hospitals and internists kind of being integrated, I just usually make a phone call and let them explain with them what I want, and then they'll order it. So, but Joe, go ahead. I know you were going to say something.
No, you just had actually one last appropriate polling question. I am going to start it, and the polling question is: do you have a better understanding of thyroid dysfunction and rheumatology and how they affect the eye to better diagnose, treat, and manage your patients? I think this would be a quick one because everybody's coming back with the answer of yes, 100%. So it was a great talk. I know this is your Sergeant Pepper's. And I thought you did a terrific job. I want to thank everybody for attending. We are going to be doing a number of other webinars. And an interesting one we have coming up, we're going to have an internist working with us. And he's got some interesting perspectives. And I know he's treated a couple hundred COVID patients. So we're going to be interested in hearing his perspective on the front line working in the hospital. So that will be coming up in just a little bit, and we'll be advertising those and putting them on our website. So with that, thank you everybody for attending. Be safe, and we look forward to seeing you live when we get through these unusual times.
Bye-bye, everyone. Thanks for attending.
Cheers.